All right, let's dive right into this deep dive and really get into it. Today we're talking about preliminary considerations for operative dentistry.
And I think it's important to start with, as always, moisture control.
Yeah, moisture control. What a concept. Why is it so important?
Well, I mean, you're trying to work in an environment that's inherently wet.
Sure.
Saliva and blood are always going to be a factor, and those are the things that really interfere with us trying to place restorations. So you need to have a clean, dry field so that you can, bond properly. You can place materials without having them be contaminated.
We need isolation for all that.
Exactly.
So what are some ways that we can achieve isolation?
Well, there's really kind of two categories of isolation techniques. You have your indirect and your direct.
Okay.
Indirect methods are more about minimizing moisture before you even begin.
Okay.
So that includes things like making sure your patient is positioned comfortably.
Right.
So they're relaxed, they're not tense, which can increase salivation.
Right.
Proper use of local anesthesia is super important, not only for pain control, but also to minimize bleeding, which can, really compromise a dry field.
Yeah.
And then in some cases, you might even consider medications to manage excessive salivation.
What kind of medications are we talking about here?
There are anti-sialagogues like atropine or propanthyline bromide, but those are sort of last resort options.
Yeah.
Because they do come with some potential side effects. Dosage and timing are really critical.
Makes sense. So that's indirect. Now, what about direct methods?
So direct methods are all about isolating the teeth directly. And the king of direct isolation is, of course, the rubber dam.
The rubber dam, the gold standard as we hear it.
Absolutely. Nothing beats a rubber dam when it comes to moisture control. It's really essential for certain procedures, like endodontics.
Okay.
Anytime you're excavating deep caries, placing subgingival restorations, bleaching procedures, really it's just best practice anytime you have a high-risk patient.
Makes sense. So when would we not use a rubber dam?
Well, there are some limitations. For example, if a tooth isn't fully erupted, you're not going to be able to get a clamp on it.
Yeah.
Certain third molars can be tricky. And then, of course, you have patients with breathing difficulties or latex allergies. In those cases, a rubber dam might not be feasible.
Right. So what are our options when the rubber dam is off the table?
Well, there are a few things we can do. For example, throat shields are super important for preventing aspiration.
Especially when you're working with all those little tiny things.
Exactly. Got to keep those crowns and inlays from taking a trip down the wrong pipe.
For sure.
And then there's gingival retraction.
Yeah, gingival retraction. Another whole world.
Absolutely essential for getting clear access to the margins and ensuring that our impression materials flow properly. We've got a whole range of techniques at our disposal.
So, what kind of techniques are we talking about here?
Well, there's the physico-mechanical methods, which rely on simply pushing the gingiva out of the way. Think copper bands, aluminum shells, even temporary acrylic copings. We can use heavy rubber dam material for retraction, or even pack cotton into the gingival sulcus, sometimes with zinc oxide eugenol impregnation.
Wow, that's a lot of options.
It is. But honestly, the workhorse of gingival retraction in most practices is the good old retraction cord.
Yeah, I was just going to say retraction cords. Those seem to be the most popular.
Definitely. They're simple, effective, readily available in a range of materials and sizes. You can use them alone or combine them with chemicals, what we call chemico-mechanical gingival retraction.
So chemico-mechanical, that sounds pretty high-tech. What kind of chemicals are we using there?
Well, the goal is to control bleeding and shrink the gingival tissues temporarily. So vasoconstrictors like epinephrine and norepinephrine are commonly used.
Okay.
Astringents or biologic fluid coagulants can also be helpful. They
Fine.
basically help to clot the blood and fluids in the sulcus.
So less bleeding, better visibility.
Exactly. And then you have tissue coagulants, which basically work by solidifying the epithelial layer and the fluids in the sulcus.
It's like creating a temporary barrier.
Precisely.
So when it comes to using these retraction cords with chemicals,
Yeah.
what are some key things we need to keep in mind?
Well, first and foremost, you need a dry field.
Right back to square one.
Exactly. Then it's all about choosing the right size cord. Too thick and you'll traumatize the tissue. Too thin and it won't be effective.
Sounds like a Goldilocks situation.
Exactly. You need to find the one that's just right.
Okay, so you've got the right size cord. What next?
You want to cut the cord so that it encircles the tooth. Then soak it in the chemical you've chosen.
And how do you actually place it?
You gently place it into the sulcus using a plastic instrument or a cord packer.
Okay.
Angle and pressure are key here. You want to start by placing the cord at an axial angle for stability. then move to the lingual surface,
Okay.
and then you continue labially overlapping the initial end. Let it sit for about 5 to 10 minutes. Moisten it before removal to minimize trauma, and then you're ready to proceed with your impression or restoration.
Great. So we've got the rubber dam, we've got retraction cords. What other options do we have for direct isolation?
Well, don't underestimate the power of simple cotton rolls, absorbent wafers, and saliva
I'll
ejectors.
have the classics.
They may not be fancy, but they're definitely still relevant, especially for maxillary and mandibular teeth. Just remember to change them frequently to maintain effectiveness.
Right, to keep those things fresh.
And of course, we have high-volume evacuators. They're a must-have for removing water spray and debris quickly and efficiently.
Much better than those little saliva ejectors.
Absolutely.
So many options to choose from. It really comes down to what works best for you in your practice.
Exactly. Experience and personal preference play a big role in what techniques you gravitate towards.
All right, so we've tackled moisture control. Now, let's talk about another big one, pain control.
Absolutely. Patient comfort is paramount. We want to make sure our patients have a positive experience, and that means minimizing pain and anxiety as much as possible.
So local anesthesia, that's our bread and butter, right?
Definitely. But it's not a one-size-fits-all approach.
Right,
We always assess pulpal status and patient anxiety before administering LA.
makes sense.
And we tailor our technique, whether it's infiltration or block, to the specific situation.
Right.
Topical anesthesia with benzocaine or lidocaine can also be incredibly helpful, especially for those who are afraid of needles.
I think we've all had those patients.
Absolutely. But for some patients, local anesthesia alone isn't enough.
Okay, so what do we do then?
That's when we consider alternative pain management strategies.
Like what?
Pre-medication with anti-anxiety agents or sedatives can be a game changer for patients with low pain thresholds or high anxiety.
What kind of medications are we talking about?
Things like diazepam, alprazolam, midazolam,
Oh.
they can really help to calm those nerves.
But those medications can have some pretty strong effects, right?
They can. So timing is crucial. We usually have patients take them about an hour before their appointment.
Okay.
And we always emphasize the importance of having a companion present, as these medications can impair reflexes and judgment.
Makes sense. Safety first.
Absolutely. And then there's inhalation sedation, a great option for mild to moderate pain and anxiety.
Oh yeah, nitrous oxide. That's a classic.
It's safe, effective, relatively easy to administer and monitor. Patients recover quickly.
So what about hypnosis? Is that something you use in your practice?
I do. It can be very effective for patients who are open to it. It's a fascinating technique that can really transform the dental experience.
So it's more about relaxation and suggestion.
Exactly.
Then there's this thing called electronic dental anesthesia, or EDA. Heard of that?
I have. It's a pretty cool technology. It basically works by stimulating large diameter A fibers, which can inhibit pain transmission.
So it's like tricking the brain into feeling less pain.
Pretty much. And it's thought to potentially increase serotonin and endorphin levels, which adds another layer of pain relief.
Wow, that's amazing. So we've got a whole arsenal of tools to help our patients feel comfortable.
We do. It's all about finding the right approach for each individual patient.
All right, so we've covered moisture control and pain management. Now, what about those delicate soft tissues and supporting structures? We need to protect those as well.
Absolutely. Minimizing trauma to those tissues is crucial for promoting healing and ensuring the long-term success of our procedures.
So what are some ways we can protect those tissues, especially when we're working in subgingival areas?
Well, we've got a range of gingival tissue management methods at our disposal.
Okay, let's hear it.
We can start with physico-mechanical methods, which basically rely on physically displacing the gingiva.
Okay.
Think heavy rubber dam material, wooden wedges, rolled cotton, retraction cords, of course, all tried and true techniques.
Yeah, good old retraction cords.
Then there are chemical methods. We can use caustic chemicals to cauterize gingival tissue. Trichloroacetic acid is the most common agent used today.
Right, I've heard of that.
It's effective, but needs to be used carefully.
Makes sense.
There's also rotary curettage, or gingidage, which basically involves using a chamfer diamond point to create a trough in the gingival tissue.
Okay.
It can be useful, but there's a risk of overextension and bleeding, so you need to have a light touch.
Yeah, I can see how that could be tricky.
And of course, there are times when surgical removal of gingival tissue is necessary, like when you have extensive hypertrophy or subgingival trauma.
Makes sense. So in those cases, we'd place a temporary restoration to allow for healing before placing the permanent one.
Exactly. Then you have electrosurgical methods, which use high-frequency alternating current.
Okay, I'm not too familiar with those.
Basically, depending on the energy level, you can achieve different effects: cutting, coagulation, fulguration, or desiccation.
So it's pretty versatile.
It is. Now let's talk about some of the newer gingival retraction techniques that are gaining popularity.
Like what?
Well, lasers are becoming increasingly popular for their ability to create bloodless incisions, remove tissue with precision, and promote rapid healing.
Lasers, that's pretty high tech.
It is. And they can be used for a variety of applications, from soft tissue surgery to gingival retraction and excision.
Wow. What kind of lasers are we talking about here?
There are CO2 lasers, NDYAG lasers, argon lasers, diode lasers. They all have their pros and cons.
Interesting. But lasers are still pretty expensive, right?
They are, and they can be slower than traditional scalpel surgery.
So they're not a perfect solution.
Not yet, at least. But there's another interesting technique called retraction by dilatation.
Okay, I've never heard of that one.
It involves using a modified silicone elastomer that produces hydrogen gas, which causes foam expansion and retraction.
Wow, that's pretty clever.
It is.
So we've got a lot of options for managing those delicate gingival tissues.
We do. It's all about choosing the right technique for the right situation.
All right, so we've covered moisture control, pain management, and soft tissue protection. Now, let's talk about the cornerstone of safe practice: sterilization.
Absolutely. Sterilization is non-negotiable. We have a responsibility to protect ourselves, our team, and our patients from the spread of infection.
So what are the accepted methods of sterilization?
We have four main ones: steam pressure sterilization, dry heat sterilization, chemical vapor pressure sterilization, and ethylene oxide